Welcome to Excellence in Practice, Voices for Better Care, a podcast by the National Centre of Excellence in Intellectual Disability Health. Here we will be sharing real stories and advice from expert clinicians and people with lived experience on improving healthcare for people with intellectual disability. We hope you enjoy this episode. I'm Ricky Kremer and I am co-hosting with Raylene Griffiths.
The National Centre of Excellence in Intellectual Disability Health recognises and respects the traditional custodians of country across Australia. We acknowledge their deep and ongoing connection to land, waters and community and pay our respect to elders past and present.
This podcast episode includes discussions about healthcare experiences of people with intellectual disability. This episode contains graphic descriptions of medical procedures and healthcare treatment, including mentions of medical mistreatment, discrimination, and death. This episode may be distressing for some listeners. If you are uncomfortable, please take a break or skip this episode. Thank you for joining us for this episode, where we will focus on the bias faced by people with intellectual disability in healthcare. In part 1 of this episode, we spoke to Dr. Jessica Smith, who shared stories and experiences about bias in healthcare and how healthcare professionals can challenge them to provide better care for people with intellectual disability. In part 2, we will be speaking to Rachel Browne, who will share the story of her son, Finlay Browne, who tragically passed away after not being able to get the care he needed in the health system. Thank you, Jessica and Rachel, for joining us to talk about such an important topic. To our listeners, we hope this episode helps you to understand the experiences of people with intellectual disability in the healthcare system. Thank you for joining us.
Thank you for having me.
So the first question I wanted to ask you is, can you start by telling us about yourself?
Well, my name's Rachel Browne. I live in central western New South Wales, in a town called Bathurst. I'm married to Grant and I have 3 children, Caleb, Finlay and Alara. I'm a registered nurse and I have worked as a registered nurse over 28 years now, 29 years. Now you know I'm old. And Bathurst is a regional town. I think we're about 176 kilometres west of Westmead, so over the mountains.
Well, thank you for introducing yourself. Can you tell us a bit about your son, Finlay? What was he like and what did he love to do and how he was an important part of your family and the community?
Absolutely, Ricky. Thank you for asking that question. I'd love to tell you about Finlay. Finlay was born in 2000. He was a millennial baby. He was diagnosed with Down syndrome after delivery. So he was what was called a diagnosis after birth. That initially was a bit of a shock to us, but momentarily we got on with life and taking a new baby home and doing all the things that you do with a new baby, getting them to sleep, feed, and just enjoying and loving on them, really. He had an elder brother at the time, Caleb. Caleb was 2.5, 3 years older than Finn, and Finlay was joined by Alara, his younger sister, when he was about 3. Finlay was happy, he loved life, he lived it to the fullest. He squeezed every bit he could out of his life. He was funny. He loved slapstick, he loved Looney Tunes, he loved singing and dancing and stirring his siblings. He thought he was my co-parent and loved to tell his older brother and younger sister quite often that they were grounded, usually for their entire life, he would say. He enjoyed going to school. He loved being included in family activities. We never went anywhere without him. We never did anything without him. Everything that his siblings did, Finlay did, and he probably did more than his siblings. Finlay, as he got older, formed very close friendships with his mates and enjoyed going on trips away with them, and was looking forward to probably finishing school and going out into the world and getting a job, and would tell me quite often that he was going to move out of home with one of his friends. So all the things that as young adolescents, beginning on our life's journey, would like to do.
Absolutely. Thank you. So he sounds like a wonderful person. Can you tell us what Finlay's experiences were like in the healthcare system when he was growing up?
Sure. Finlay's many encounters of health, and there were lots of varied interactions with health from when he was really little, allied health physios, occupational therapists, through early intervention, speech pathologists, hearing, audiologists, ear, nose and throat surgeons, paediatrician, and he saw an ophthalmologist also, regular, annual blood tests, and then there were the presentations to emergency department. So we had with Finlay a lot of interaction with health, and unfortunately the poor interactions outweighed the good interactions. In fact, I can probably think of less than half a dozen positive interactions, and they've sort of left a mark on my memory because they were exemplary and they were a standout moment because other interactions were so poor. And as we went along, we realised this, and I guess naively as, parents traversing or navigating life with a new baby with a diagnosis of Down syndrome, it was a new world for us. To us, he was just our baby, our son. We were always gobsmacked when we had these poor interactions. It could be from people's lack of time, lack of care, to thinking they'd diagnosed, in fact, that Finlay had Down syndrome, that somehow that we didn't or weren't aware of the fact that Finn had Down syndrome, which is quite incredulous. And we would often laugh about it, but it, not funny at all. But we just sort of kept rolling along with those interactions. The interactions, with annual blood reviews and any x-ray or thing like that were quite invasive, were handled particularly poorly. And Finlay needed time, like any of us, to understand what was going to happen. And we use social stories quite a lot, to set the scene of what was about to happen. In an emergency situation, unfortunately, you don't often have the opportunity to do that. We would, if we had to take Finlay to the emergency department, it was something that we didn't do lightly. And in fact, a distressing part of Finlay's final presentation to the emergency department. The day before, a colleague of mine in allied health had given me a little cartoon cutout of, basically someone saying that they'd have to be dead to present to an emergency department. And I've reflected on that quite a bit. She'd had poor experiences in another realm, just, with accessing emergency department. And I guess I'd spoken to her about this fact before. And that little cartoon caricature actually came to fruition the next day. Unbelievable still, but I felt that over Finlay's 16 years of living vicariously, sharing his world, I wasn't the person it was happening to, it was Finlay, but I observed these interactions, as did his dad, Grant, for 16 years. And they set the precedent for what happened on the 30th of September 2016, I guess. And it's something that I often say as a mum, I felt possibly could happen and lived in fear of that happening, and wished it hadn't, wished I'd never felt like that. But that's what was observed.
Yeah, thank you for sharing. Can you tell us about what happened when Finlay went to hospital in 2016 and what led to his passing?
Yeah, so that week in 2016, Finlay, only 2 months before, had turned 16, and it was the second week of the school holidays in New South Wales, and I was off that particular Friday, and we started the day like any other ordinary day where I was off, and he got himself showered and dressed, and he came out and had breakfast and just the normal banter that we would have. He was on his iPad, I was making brownies, and it wasn't very warm that September because Finlay would normally school holidays around September, beginning of October, would get into the pool if he could. It didn't have to be too warm. He loved swimming, but it was still unseasonably cold for that time of year. And I can remember what he was wearing. We were sitting there chatting and he was on his iPad, and then a strange expression crossed his face. And I said, "Are you okay?" And he just sat there, and the next thing I know, he'd gotten down on the floor and was laying prone with his tummy on the floor. We have a tiled floor. And he'd pulled his shirt up, and he started moaning and groaning, and then he started dry reaching, and I took him into the bathroom to see if he needed to have his bowels open on the toilet, and he proceeded to start vomiting, and it escalated from there. And over the course of an hour and a half, so this all started around midday on the 30th of September, I got him in the bath. He had his bowels open in the bath, and there was blood in his poo. What he was vomiting smelt. It was brown. It was really offensive and looked to me like it was feculent, which means that it was poo also. And soon after, I contacted my husband, Finn's dad, Grant, because I was panicked. I was asking his younger sister how he was the day before, had he been eating, and she was telling me just to ring an ambulance. And Finlay was begging me to help him. I can remember him just saying, "Please, Mum, please help me. Please." I knew it was serious. A few things happened in the next couple of hours. I got him in the shower to clean him off. tried to give him some Panadol. His dad arrived home. He was 45 kilometres away, so got in the car and came home. I had a look at Finlay's tummy. I was starting to think it might be appendicitis or something like that. It had crossed my mind that he probably could have had a bowel obstruction, but he'd had his bowels open a fair amount, so I dismissed that. Now, Finlay hated going to hospital. He really found it confronting, and we always had, maximum effort to get him in the car to take him. And on this occasion, he put himself in the car. And I guess, I knew how serious it was, but that sort of was an indication to me of absolutely how serious the situation was, that he was quite amenable to going to hospital. I was panicked. I had looked at him and I thought his hands were cold. He looked very pale. As a nurse, he was not looking great to me at that time. We only lived really 2 minutes away from the hospital. So we took him to hospital. My husband let me out the front of the hospital and I helped Finlay, who was still dry retching, vomiting at this time. I had a bucket in the car with me, which I left in the car. We got through the sliding doors of the emergency department shortly after 4 o'clock. And I remember looking at the time, looking around, the waiting room, quickly scanning to see how many people were there. Went over to the clerk. I'm sort of supporting Finlay's body weight and giving our details to the clerk. Finlay's collapsed down, face down on the ground again, prone on the ground, writhing around in pain, and triage nurses come out of the cubicle and indicated to me visually, she rolled her eyes. She may not have meant to. She may not have realised that that's what she'd done, and she sort of had her hands on her hips as if to say, what have we got here? And I immediately had this sinking feeling, and it's terrible, but I recalled at that moment thinking basically that Finlay was in big trouble and we were probably not going to get out of there in a favourable condition. I felt that because it was going into a long weekend and a Friday afternoon, that there was a possibility that we'd taken him to the emergency department, because I was not able to cope with him at home. When we got into the triage, Finlay was still dry reaching. They wanted to weigh him. And I think they did his SATs to see how much oxygenation was happening, what his pulse was. I'm telling them that, the week before school ended, there was a note come home about norovirus, but he'd had blood in his faeces that afternoon. I was wanting it to be norovirus by this stage, and that was the worst thing I could have uttered because I think it was a red herring and they just hung on to that whole thing that it was a gastro case. He's vomiting and but he didn't have diarrhea. He'd had blood in his faeces, and that interaction in that triage cubicle was very quick, and it was one of sort of ushering us out the other side, if you like. Get him in, get him seen to. I was panicked, but Finlay was not being seen in that moment as someone who was acutely unwell and exhibiting discomfort. And unfortunately, that's when the start of probably, he's non-verbal. He's got Down syndrome. The thought of that is trumping anything else clinically. And we were put on a bed called a short stay bed, which is neither a bed admitted into the emergency department or but a holding bed, if you like, probably to discharge someone home potentially. We were triaged as a category 3. I later found out, which the nurse attributed to him just because he had Down syndrome, not really on the basis of what his symptoms were, or at that time his pulse was 110, so he was tachycardic for Finlay, but they didn't know that. They didn't know that Finlay had a resting pulse, of around 50. So we ended up in this no man's land from about 4:30, 4:45 till 6 o'clock, where Finlay continued to vomit, and people avoided us, and his stomach was becoming more and more distended, and he was begging me to help him. It wasn't until 6 o'clock that an emergency department medical officer sort of examined him. We had been seen briefly before that by a junior medical officer who, was very young, and he had encouraged me to get Finlay to drink, and I was a bit horrified by that because of the amount that Finlay was vomiting, and then wanted to know how difficult Finlay was to cannulate. And I said, well, he doesn't like it. So I was a bit short with him because I thought, what a silly question. No one likes to be, have an invasive procedure. Finlay, probably less than anyone else, he wouldn't engage with Finlay. He turned his back on Finlay, as a matter of fact. And I wanted Finlay to know that this fella was a doctor and was here to help him. And I said, would you please talk to my son? We finally got into the ED about 6 o'clock. They did some bloods and put a cannula in Finlay's right hand at that time. A nurse congruently wanted to start, doing blood pressures and things like that, which was upsetting Finlay. Like, we were just concentrating on this invasive procedure. Once his bloods were taken, they hooked up some intravenous fluid. And one thing about that interaction was that normally Finlay, in a particular situation where it involved, taking blood, cannulation or anything invasive like that, didn't like it, and, often Grant and myself would have to hold him to allow that to happen because of experiences in the past. He had quite a lot of trauma relating to anything like that. And he, at that time, was remarkably pretty easy, in terms of what he normally would be like to cannulate. He said, ow, that was sort of it. And that really concerned me. Worryingly so. I knew that there was something more going on, that Finlay was really sick. They started to give Finlay fluids. He'd had no pain relief at this point. And, with very little interaction, another hour and a half or so passed. No blood pressure. I was getting more and more desperate. Someone came and let me know what his one particular component of his blood work was, and that was his lactate, which was 7.2, which is very abnormal, anything over 2. And in fact, since Finlay was unwell, I think they've reduced that again, but anything over 2 causes concern and alarm, and you're looking at a pretty sick person. So Finlay's was 7.2, and my heart sank, and I said to that person, Finlay's going to die. And they said, no, he's not, don't be silly. I was concerned that my son needed urgent help and he wasn't getting it. I was concerned that that was another marker indicating how unwell Finlay was. And there was this inaction, I guess. If I had seen anyone with a lactate of 7.2 exhibiting abdo pain, distended stomach, on the ward, I would have been concerned. In fact, a clinical review would have been necessitated, and it wasn't. So there was no increase in monitoring Finlay from that viewpoint. There was nothing. We were in the corner, at the back of the emergency department, out of plain sight, near the laundry room, with no one checking in really on Finlay. No one had examined him again. And eventually we were sent off to have a CT, and Finlay was pretty compliant. He had to have contrast. I went with him into the CT. He held still for the CT. He had the CT with communication, explanation. He was scared, but he trusted me and he was compliant, enough to have that CT done. Now, the worrying thing after that CT occurred, there are a couple of things. The EDMO realised there was an anomaly, a congenital anomaly that Finlay had been born with, not because he had Down syndrome. Anyone can have a congenital abnormality, and it showed that his small intestine, cecum, weren't where they should have been, and he had basically had this twisting effect, and they'd cut off the blood supply to his gut, which is his stomach, small intestine, all the things that, assist with digestion, essentially. So at that point, they knew the cause of his deranged blood work. And I know hospitals, particularly emergency departments, aren't like the shows on TV. Things don't happen straight away. However, still, with this knowledge, there was no sense of urgency about aiding my son. In fact, with that knowledge, Finlay just needed an operation to open him up and unkink the kink to restore blood flow. It was time critical. Instead of looking for an opportunity for that to happen or getting him to theatre, an elderly lady was taken to theatre, which then meant that they didn't have a theatre available to look after my son. Now, I asked the ED medical officer if he was going to get Finlay out, and what I meant was Finlay needed to be in a different sort of hospital, given how sick he was. Our size hospital wasn't going to be able to deal with what he had after it was untwisted, but he needed intensive care. And I was told that they would get him out. The emergency department medical officer seemed to be having his own issues on that afternoon and walked off, left at 9:30 at the end of his shift without seeing my son again. We never saw him again. We still continued to have very little interaction. Finlay had minimal pain relief considering what was going on inside of him. And when the night staff shift came on, someone realised that it had been hours since he'd had a blood pressure done and he'd had some IV morphine, and they'd better do a blood pressure. By this point, I knew Finlay was in serious trouble because he was begging me for water. He'd had no urine output since he woke up in the morning. So we'd gone hours and he'd had a couple of bags of fluid in. So no urine output. So things are going pear-shaped from that side of things. He continued to vomit. He was getting paler. His stomach was getting more distended. My husband realised how unwell he was. I think any layperson who at that point came across Finlay would have gone, gee, he looks crook. I was had been asking them to put a nasogastric tube in because I knew that would stop some of the distension and his vomiting. I was worried about him aspirating that vomit. Eventually, Finlay started to beg me. After seeing a tap in front at a sink, he's begging me to get water out. Why aren't you listening to me, Mum? I want water. There's a tap there, Mum. And I said, you can't drink. And so he said, soup. Can I have some soup, Mum? Now, Finlay had quite a restricted diet. Finlay also had pervasive development disorder, so he had some aspects of being neurodiverse, and so his diet was rigid. So him asking for soup was a really major red flag for me, because there's no way, I don't think Finlay in his lifetime had ever eaten soup. That's how desperate for some fluid he was, which was concerning, because people, when they're very sick, hypervolemic, get very thirsty. They then hooked him up to a blood pressure cuff after my husband helped, after the nurse who had been charged with his care made an accusation that she could not do Finlay's obs because he was combative and he wouldn't let her. And my husband said, let me put the cuff on. So he put the cuff on. They looked at the machine and didn't believe what the blood pressure was, because his systolic was 80 at that stage, which is very low. Most normal people are around 125 for that systolic number. A nurse who'd come on that evening, who was an enrolled nurse, then manually did his blood pressure, and I could see it on the sphygmo, and it was in actual fact even lower. It was 70 was his top number, and nobody believed her. They implied that she didn't know how to take a blood pressure. And then I asked them, begged them to take my son to resus, because I knew that potentially he was going to have a cardiac arrest at that point. At that point, they became fixated with putting a nasogastric tube down my son's nose. So that required holding his head, putting a tube down his nose. Finlay was tactile defensive, as I said, around his head. He didn't have any more pain relief at that point. They realised that, in fact, the cannula that he had in from the Agilia pump connecting his fluids that had been alarming for several hours was not pumping fluid in, because his cannula had tissued, so he had no access. They could not at that point get a blood pressure at all. So he was in critical danger. So they took him into main resus, and I think multiple people around the bed at that time. They made a diagnosis of hypervolemic shock. They still couldn't find a blood pressure on him. And you can imagine, when you're very sick, you're in a place that you're scared of, physically scared of, that you feel that unwell, that you probably know you're going to die, and people are trying to hold you down and telling you you're naughty, and security's called. Now, Finlay at that point was fighting for his life. By that point, his lactate actually was up around 10 and it had crept up to 16, really not compatible with life. They managed to get a wide bore cannula in and prepped him at that point to take him up to the theatre because they needed to intubate him and give him medication to try and keep his heart beating. Once he got to theatre, which was about 12:30 that night, I waited. My husband had gone home prior to Finn going to theatre, so he was not even aware that Finlay had been taken to theatre. About 3:30 the next morning, so nearly 12 hours after we presented to the emergency department, the locum surgeon who performed Finlay's operation came to see me to tell me how sick Finn was, which I already knew. About an hour after that, the doctor who was charged with retrieving him via fixed wing back to Sydney came and saw me. In all the interactions I'd had in those 12 hours, that doctor was the only person in this very brief interaction that got a history from me about Finlay, about his health, about his autism, about previous bloods he'd had, which showed that, he'd had vitamin B12 deficiency, which probably, hindsight's a cruel master, but were reflective of the lack of uptake from his small bowel of nutrient because it wasn't functioning. But that doctor took the time to ask me appropriate questions. Finlay then, by 5:30 in the morning, was retrieved and flown to Bankstown in Sydney and then taken via ambulance onto Westmead Children's Hospital Paediatric Intensive Care Unit, and he was very unstable for several hours. The plan was to go straight to theatre, but he didn't. He required some time to stabilise him. They took him to theatre in the afternoon. He was very sick. He went on to have 12 surgeries in total, spent 65 days in the paediatric intensive care unit. We did spend a week on the surgical ward, but unfortunately he had to go back and have further surgery. And it was compounded by that initial onslaught, lack of time. His lactate, caused massive stress on his organs. Had some renal failure, heart failure, so he was not in good form, and most of his small intestine, you have as much as you are tall, small intestine had to be removed. And you can't live, unfortunately, without a digestive tract, and he was on total parenteral nutrition through a port straight to his heart that would require management and risk of infection and so forth. So that was going to be very difficult to manage. But ultimately, even though Finlay had periods where, he was alert and awake and talking to us and not ventilated and able to communicate and ask what happened to him, and would participate in rehabilitation. He'd been in bed a long time, he'd lost a lot of weight. Things were very grim for Finn, and ultimately we, as Finlay's family, had to start having courageous communication with the team treating him, who went above and beyond and tried to save Finlay, but unfortunately the damage had already been done and he'd suffered a catastrophic injury. And it was amazing that Finlay survived those 72 days after, which are testament to his character and his love of life, but his love of us, his family, and battled on because, we were with him every day. So we, as his family, met with his treating team and requested that Finlay be removed from the very things that were keeping him alive. So all those supports, and allowed to have a death with dignity and on his terms, which is a very difficult thing to do as a family and a mother, when all you're wanting to do is save your child and bring him home.
Thank you for sharing that, Rachel, and we're deeply sorry for your loss.
Thank you, Ricky. Thank you for asking and for listening. It means a lot to myself and our family to tell Finlay's story.
Yeah, it's absolutely, I think, very crucial for everyone to hear this. So, how do you think bias impacted the care that Finlay received?
I think, unfortunately, and I wish it was different, that every non-interaction with Finlay, every marker that for an individual, if it had been me in that bed with a lactate of 7.2 or complaining of pain or with a distended stomach, there would have been more done. It's obvious to me, and this is formed by my experience and observation of how Finlay's interactions with health went over the years, that there's a bit of dancing around the obvious. I think health professionals probably don't know that they do it. It's not intentional, and it's probably compounded by a lack of knowing and understanding, unfortunately. But that's not good enough, because apart from the diagnostic results that health professionals love to look at, if they'd looked at my son Finlay, they would have seen and taken on board that there were obvious physical characteristics of him being unwell. And the only thing that I can deduce from this is that, unfortunately, with Finlay, having a diagnosis of Down syndrome makes his disability and his intellectual disability more obvious and apparent to people. So then there's a perception that they know about people with Down syndrome and what their health issues, for want of a better word, are. And I perceive that every opportunity they had to enact or elicit more urgent care for Finlay was missed. Case in point, that initial lactate at 7.2, they thought that could be due to an anomaly, that wasn't right. That because he was non-verbal, that, they'd test him for everything. But when they tested him for everything and they didn't speak to him about where his pain was or how he was feeling, his blood work was completely deranged, but then they dismissed that. So every opportunity they had to collectively go, we've got a kid in trouble here. We need to do something about this. They didn't enact that care. The fact that they felt Finlay was combative, and this was another thing, another issue, was Finlay communicating to them how sick he was. He wasn't being combative. He was communicating to them how unwell he was. So I really think, and the final thing, which could never be, rationalised, was that a lady who'd been waiting for 5-6 hours herself in the ED after a motor vehicle accident, was an 88, something like that, an octogenarian, was taken to theatre prior to my son, who was probably one of the sickest people in New South Wales on that afternoon. The other thing that concerned me was that these people were making decisions about my son and his potential outcome, his health outcome after this catastrophic event, without discussing this with myself and Finlay. So, many examples of bias in motion were played out on that afternoon through to that night, unfortunately.
Thank you. So, it's good to sort of highlight these biases. It's pretty important for other people that also get affected by it. What would you say to healthcare professionals about how to better support the people with intellectual disability that they are treating, and how can they overcome biases?
I think first and foremost that Finlay was a human being. Finlay was our son, our brother, a friend, and he happened to have a diagnosis of Down syndrome, but he was Finlay Browne first and foremost. And just because, you work in health and you've had an interaction with someone with Down syndrome doesn't mean you've had an interaction broad spectrum with every person you're going to come into contact with thereafter with Down syndrome. You've met one person who happens to have a diagnosis of Down syndrome. Finlay had his own quirks, his own ways that he needed to be communicated to also. So I think treat the person first. Speak to them first. Ask them first. I'm his mother. I was in the room with him, but Finlay was 16. If you put yourself in Finlay's shoes as a 16-year-old adolescent and you've got someone speaking to your mum, or if you're in your 20s even and have someone referring to your mum when you're the person on the bed, how would that make you feel? Finlay could communicate. He communicated differently. Acknowledge the person, acknowledge the situation, acknowledge that we have had encounters with health that are less than favourable. And unfortunately, we bring some baggage and animosity with us. Please don't ever feel that it is a personal attack on you, the health professional delivering the care or support. You just happen to be the face in front of us at that moment. You don't know our history. Please ask questions. Don't be afraid of asking stupid questions because there aren't any. Take the time. It may only be 40 seconds to get to know the person in the bed. if you get to know the person in the bed and then speak to their supports who are supporting them about how best to negotiate what they need and what's going to help them, it will mitigate time spent in the future. I know health professionals are time poor, but sometimes it's just the little things to allow yourself the time. I know health professionals don't really want to build relationships with patients because we understand that they're dealing with life and death situations and they've got a shift to get through. But at that moment, that interaction with my person, with my child, is the most important interaction you'll have in your shift.
Absolutely. Well, thank you for your time and for sharing Finlay's story. You're making a huge difference in improving healthcare for people with intellectual disability. Thank you for being on the podcast.
Thank you, Ricky, for taking the time to ask about Finlay and who he was and to share his story. I share his story in the trust that people will discuss what happened to Finlay and perhaps educate themselves or start courageous communication with others in healthcare. We've got a long way to go, but I can only hold on to some courage that we will get there.
Absolutely.
Thank you.
Thank you for listening to part 2 of this episode on bias in healthcare. If you've been affected by anything discussed in this episode, please know you're not alone. Support is available. If you're in crisis or need someone to talk to, you can contact Lifeline at 13 11 14 in Australia. We hope this episode helped to highlight the real consequences of bias and difficulties getting access to appropriate care for people with an intellectual disability. To learn more about the work of the National Centre of Excellence in Intellectual Disability Health or to get involved, visit our website nceidh.org.au.